Elekta lunch symposium session. We'll have 3 speakers. I'll introduce the other speakers. One is me, but the others 2 are 2 good friends and colleagues and great medical physicists. And so this session is going to deal with 2 main subjects, one being stereotactic radiosurgery, and the second subject is adaptive radiotherapy. So these will be the 2 main topics. My suggestion would be to let the presentation run and collect all the questions at the end, because I'm afraid we are a bit short of time. So it's my pleasure to introduce first Professor Serenella Russo, medical physicist from Bagno, Ripoli, Santa Maria Annunziata Hospital in Florence. And she will be speaking about the whole procedure they underwent for ISRS certification for VersaHD. As you know, ISRS, International Stereotactic Radiosurgery, is an organization dedicated to collect all the different experiences related to stereotactic radiosurgery, to promote stereotactic radiosurgery, and to produce guidelines that all the countries normally should somehow implement and follow in terms of good use of stereotactic radiosurgery, regardless, of course, of the device they are going to use. So Professor Serenella Russo is going to introduce us to this argument. Second talk will be about MR-guided radiotherapy with Elekta Unity with Professor Sotiris Stathakis, good friend. We have been doing a lot of work back in the times when he was professor at the University of San Antonio in Texas. Now he's at Perkins in Louisiana. So he's going to introduce us to the evolution of the concept of MR-guided radiotherapy decline over a 1.5 Tesla device. And last, it's going to be me. I'm a medical physicist working since 17 years in Elekta as a senior scientist in the medical affairs teams, and I'm responsible of clinical research and clinical trials. So with no further ado, I'll leave the stage to Professor Serenella Russo for her lecture.
Thank you, Roberto, for the introduction. Thank you to Elekta all for inviting me to speak about our experience about the ISRS certification of our new VersaHD that we installed just in April in our hospital. And we performed this certification because we are going to treat a lot of stereotactic treatment radiosurgery, and we would like to have an independent audit in order to verify our procedure, not only for the dosimetric, from the dosimetric point of view, but also for the entire procedure. And we would like to test our quality for the treatment planning by using, that has been done by using the Elekta 1 platform, and especially for the useful properties to reduce the dynamic lift thickness by using this system with the VersaHD platform. Allora, facciamo così. Just to introduce my department, we are in Florence, in the south part of Florence. We have about 10 radiotherapists. The chief is Silvia Scoccianti, that with me worked before in Careggi Hospital, that is the University Hospital of Florence. We are another department, but we collaborate with them for a lot of topics. We have 2 medical physics experts. One is me, the other is one of my colleagues that are dedicated to the radiotherapy, and the other 2 are working with us in radiotherapy, but also in all the other for nuclear medicine, not nuclear medicine, but for radiology and all the other fields where the medical physics are involved. And we have about 10 RTT, and we have also some nurses, and we are lucky because because we have a radiotherapy with the light, so it's very important. I think also for the staff to have, we are in the -1 floor, but we have an access to the light. So this is a very good option for the workers. And we have now 2 VersaHD mirrored LINAC, so we can share the patient between the 2 LINAC without any problem, because we have done the acceptance, also the verification that the beams of all the energy that we have are mirrored. And this is very useful, because mostly for the patient, because they can do treatment in both of them, and if possible, we try not to leave any fraction, and to be try to do all the fraction all the day for all the patients. We have scheduled in some way that we have a time to have the possibility to share the patient between the 2 LINAC. We perform a gated treatment delivery since many years ago, because we have the CRAD SGRT system, and both at the CT and at the LINAC, so we can acquire prospective gating for the CT or retrospective for the CT, and we use both gated treatment for both the LINAC. And we are very we spend a lot of time in accuracy, verification, and precision. And we, for example, for immobilization system for SRS, we use a double mask. That is a system that we tested and we implement because of the accuracy that we can get. We, as told, we use motion management, different modality to delineate the targets, and we use for the planning, our platform is Monaco, and is a Citrix-based platform, so we can use from any computer for each of the user can run Monaco, and this is very useful, mostly for the medical doctors to review the plan. About the PSQA, we have different systems. The last one that we tested was the ΔΔ1, that was particularly important for SRS treatment. For MRgRT, of course, we have been using for the CT beam since many years, because of the utility that we get for motion management treatment, and surface gating, and in vivo dosimetry for particular cases, and for in some way we use in vivo also to speed up the adaptive process. And about this presentation, we will see which is the process about the ISRS certification, how we performed with this institute, and which are the standards that they required. In our hospital, the certification was done for one of our VersaHD, and the process was divided in 3 phases. The first one was a preliminary meeting that we have with the certificators. They would like to know which kind of treatment we perform for SRS treatment, which are our system, the model of our LINAC, and the model of our treatment planning system, and some specification about our QA equipment. So we have to fill a form, and they evaluate this, and they approve this form, and then we move to the on-site visit. We have a visit from directly Ian Paddick, that is the chief of the community of the ISRS certification, and by a medical physics and a radiotherapist from another hospital in Italy that are certificator for the ISRS Institute. And in this 2-day on-site visit, we have to review with them all our procedure, starting from the training of the staff, level of education, and so on, and going on to all the steps of the treatment procedure. So we review the imaging, the treatment planning, the delivery, everything, and they evaluate our procedure, our written procedure, and our online procedure with us, because they would like to see also some kind of treatment that we perform together in the day that they are with us. And we also performed the dosimetric audit, that is a key part of the certification, that is done by using the RT-safe phantom that we will see later. And then at the end, we would like to have the certification, that is the final step of the process. As I told you, the dosimetric audit was based on a remote end-to-end dosimetry service that is performed by RT-safe dosimetry company, and this company offer also a pre-certification, a preparation for the ISRS certification that we have performed before the real certification procedure. So it is very useful for us, because we have the possibility to understand which kind of test the ISRS required us, and to evaluate, to perform all the procedure, and to evaluate our results. Fortunately, they are good, so we can move to the real certification. And again, in both of these process, we use the same phantom, that is the RT-safe prime phantom, where it's possible to insert GAF-chromic ABT film that are calibrated at the secondary standard dosimetry laboratory at the Greek Atomic Energy Commission, and we got in advance some the images, the two dataset images of the patient with the insert of the GAF inside. One is with detector in the sagittal direction, and the other one in the coronal direction. And in the same condition, we perform also the measurement at the LINAC in these two different conditions. During the real audit, the prime phantom was filled by water. This is a plastic phantom that mimics the head of the patient, and we can put inside the water and all the detectors, the GAF-chromic, but also some other detectors. They have also the holder for some other detectors, and we use them, are inserted after the phantom has been filled by water. And we perform the scan in our CT facility, and we register the reference data set that they gave us with 3 different targets of different size, and some organ at risk, mainly the brainstem, that is the more important organ at risk for the proximity to the targets, on the data set that we have acquired to in our facility. And we performed a treatment plan for VMAT SRS treatment, following the local protocol, and we also add to the phantom, because we would like to test a real treatment for a patient. So we also add to the CT reference data set some organ at risk, together with the medical doctor, in order to verify that our template that we are using in Monaco for the planning is really can really achieve the certification, because it's the same that we are going to use for the patient. And so we performed the plan, and we got as we will see, very good results, and at the end we save the DICOM-RT plan, dose and structure to send to the RT safe for the verification of the measurement done by the GAF-chromic. And this is the one view of the plan with the detector in the sagittal direction. This is in coronal direction. As you can see, we have 3 targets. The first one is, as I can say, a big target because it is about 3 cc. The other one are very, very small, one 0.27, the other one 0.4 cc, so they are very, very small. And these are the requirement from RT Safe and from the ISRS Institute that we are asked to achieve during the planning process. In particular, we have to work a lot on the gradient index because what is required is very, very restricted. And the procedure was performed in our new LINAC, so we plan with 5 non-coplanar arcs, and this is the video of the measurement that we have done in our department. Of course, by using this kind of field, we have to be careful and to adjust our QA protocol for this kind of treatment. I mean, for non-coplanar beam, for the verification of the coincidence between the radiation isocenter and the isocenter of the couch, for example. And I require to see during the certification which is the procedure and the tolerance that they use, and I have to approve them. And this is a particular of the Phantom, where we have the GAF-chromic insert, but also the insert for other detector. In particular, we use the one for the microdiamond because we have, as we will see, a microdiamond calibrated in absolute dose, but we also perform during the certification a verification with the semi-flex chamber provided that we aim to verify the dose at the center of the largest target. And this is the results of our preparation for the ISRS verification performed by RT Safe. We can see that it has been evaluated both the end-to-end dosimetric and geometric accuracy by using the GAF-chromic film, and they gave us results about absolute dosimetry agreement with the treatment planning calculation by using different metrics and different gamma criteria. In fact, we see that they approve our results by using a passing criteria of 5% 1 millimeter for global gamma evaluation, but we asked also to have results according to 2 millimeter 2% and 3% 1 millimeter criteria, because they are the one that we use for our patient for the verification of our treatment. As I told, we perform also an absolute measurement with the PTW microdiamond that was calibrated in absolute dose at our reference institute, our reference laboratory for metrologic evaluation of the detector, that is the ENIA Casaccia in Rome, and we perform very, very good results for the measurement in the center of PTV1, about 1%. And so the preparation for the certification was good, and we went to the ISRS certification, and these are the standards that they required for each of the steps of the treatment. As I told, they cover all all the step, and they would like to they would like also to verify our quality management and risk and clinical risk management. So it's very important to have all these kind of procedure well assessed also for this kind of topic. As I told, they required there are guidelines from ISRS, for example, for the use of multi-leaf collimator of particular thickness, and this is achieved by Elekta strategy by using different properties, for example, the speed of the diaphragm or the leaf speed, and in this way it's possible to reduce, for example, the leaf widths and to move to thickness that are smaller than the physical thickness of the leaves. And also this is very important because we can try with this kind of platform targets that are very small, as I told at the beginning. The last target that we plan and the last patient that we treat this week was 0.3 cc. So this is real what we can do with this kind of platform. And this is probably this possibility are gained by using the modulation of low dose that can be achieved by the Elekta 1 platform that is able to modulate the low and the high dose, improving the target coverage, but reaching steeper dose gradients. And this is very important for stereotactic radiosurgery, stereotactic treatment, as both for the dimension of the targets, but also for the proximity to organ at risk. So this is what we can do. We perform multiple target single laser center treatment by using this platform, and this is a very good option, in my opinion, to have also the certification of an external auditor, because it's important that we have to verify the quality of our treatment. Thank you very much.
Okay, thank you. We'll leave questions for the end. I invite Professor Sotiris Stathakis.
Thank you. Kalispera. Thank you, Elekta, for inviting me. Thank you, Roberto. I'll try to keep mine short to save some time. What I'm going to present is how we have been using our Unity over the last 9 months at Perkins Cancer in Baton, Rouge, Louisiana. These are my conflicts of interest that you're going to see some slides from. So before I start, I would like to explain what is Perkins. And Perkins is, it covers the whole Louisiana. We have 10 cancer, 9 radiation therapy cancer centers out of the 20 that we cover. All of them have medical oncology, but only 9 have cancer radiation therapy. Across of all our centers, we have 12 Linacs, 1 Gamma Knife, now 1 Unity 2 HDRs, 7 PET CTs, and 1 MRI SIM. My team has 15 medical physicists, 10 radiation oncologists, and we treat about 3,000 patients on an annual basis. And it was a question, how does Perkins elevate the care in Louisiana? What do they need to do? How are we going to be the tide that lifts all the boats? And we said that we're going to do adaptive radiation therapy, and we had 3 options. I found the Unity when I got there. They had 3 options, of which they chose the MRI Linac by Elekta. So as you probably know, the Unity is a 1.5 Tesla MRI that has a ring, 7 MV Linac. It rotates at about 6 RPM and provides a field of view of a field of treatment of 57 cm. So why MR-guided therapy? Because it's obvious that although we might be able to see some of the smaller tumors with CT, it becomes a lot harder with CBCT, but it's better visualized, especially soft tissue with MRI. However, furthermore, actually, daily changes, respiratory motion, even the rectum and the bladder filling that we are seeing on every day, it's another justification of doing adaptive radiation therapy on a daily basis. We have seen a lot of things that are moving, are changing, even as we treat. We are hoping that in the next month and a half, we will upgrade our system to do comprehensive motion management, and I'll have a little more to say. I'm just speeding up now. I'm giving you the auction style, as we say, talk, to further reduce the margins of our targets. We're also going to see a few more examples of patients that we have treated. These are some of the reasoning for the adaptive radiation therapy with the MR-Linac. And as you can see, even on this slide, the bladder size changes from day to day and actually during the treatment. We're looking at our options, how to improve our treatments, how to improve our patient workflow, how to speed up our patient throughput. And one of the options that we are trying to do is by going with MRI-only radiation therapy by the means of therapanesia, and to produce synthetic CTs for our reference planning. According to Elekta, the Mary Bird Perkins Cancer Center Unity was one of the fastest ramp-up unities, they say worldwide. I don't know if they were flattering us. So we started, our first patient was December 11th, 2023. By end of August of 2024, we had treated more than 100 patients. Our daily load has jumped to 14 patients a day, which means close to 12 to 14 hours of treatments. And it has put a lot of a burden on our staff. I'm not going to say a whole bunch because I also have another talk later on about MRI-guided therapy, so I'm not going to spill all the beans, but it takes time for each treatment. I have another 6 slides altogether, and I'll give the podium to Roberto. But when you're treating 14 patients a day, the day starts at 7 and doesn't finish before sometimes 8 or 9 o'clock, which does not give you time to do your patient-specific QAs. For whatever reason, in the USA, we still do it. It doesn't give you time to test things. It doesn't give you time for preventive maintenance or anything else that you have to do to take care of your MRI Linac. So the next 5 slides show some of our patients that we have treated so far. Our patient load is mainly prostates. We do prostates 5 fractions, 7.25 gray per fraction every other day. And the prostate patient load is 50% of our load. We have treated everything from the neck down, including an axilla and a cardiac sarcoma. So here is one of our first patients, and this is the reference CT. This is the CT that we will use to do our plan. This is the plan that we will never treat with. We will never treat with this plan for this particular patient ever again. Every time that the patient comes in, a new plan is created on the fly. And the reason is this. So this is the patient coming in for the first fraction and the second fraction and the third, and this doesn't change from patient to patient. You can appreciate the size of the bladder and sometimes the size of the rectum, either because of air bubbles or stools that are going through. And if there's nothing, this would not be taken into account when you're treating a patient with a conventional C-arm LINAC, but with a Unity you do. This is one of our liver cases. The arrows show the location of the lobe of the liver, and I don't know if I can go back and forth. Yep. So you can appreciate how, again, soft tissue is changing between fractions, between the reference CT and the daily MR. Another liver with two lesions that now looks like that. You can again see differences in the proximity of the heart and how the liver, how squishy, as we say, is the liver is, and changes shape from day to day. This was a 15 fraction liver case that we did because of the size of the targets. We have also treated an iliac node. I'm not sure if you can see the green lines that denote the bowel in this case, but again, without adaptation of the plan on a daily basis, you will not take into account the size of the bowel that has changed, and you take into, and that way you can take into account. Before I finish, we are excited. We have done all the steps necessary, both hardware and software. We're waiting for the new version of Mosaic, the new version 3.22, hopefully. It will be installed successfully at the end of this month. Maribor Perkins is probably going to be the first one with that version of Mosaic globally, which will allow us both to operate our Harmony, but also to go and obtain access or the ability to do comprehensive motion management. With comprehensive motion management, I think our number of patients probably going to further increase, and fortunately or unfortunately, more lung patients are coming. We do not treat a lot of lung now. Comprehensive motion management will give us the option to either use free breathing and pause the beam when the excursion of the target is outside some tolerances, or gate the beam, or do breath holds. Furthermore, with comprehensive motion management, all the other targets like prostate will have a motion monitoring that is going to automatically pause the beam when the target moves away from the margin that we will be setting. Lastly, I would like to recognize all the people that are working on this project. I have a very small part. I'm doing a whole bunch of reference plans right now, and hopefully Roberto is going to show me more tricks to do them more robustly and more and faster. But Dr. Compton is our medical director for the adaptive program. Dan Eck is our clinical medical director, medical physics director. Chris Snyder is the adaptive radiation therapy technical director, and a whole bunch of more physicists and students that are doing research and technologies that are treating patients on a daily basis. So hopefully I can give you now 9 minutes.
Fantastic.
Thank you. Questions?
So thank you so much for being on time so that I can be a bit more relaxed. Just kidding. I'll keep my questions for the end of the session. All right. I'm going to introduce the Elekta EVO. After the experience with MR-guided radiotherapy and with Unity, this year at Astro we introduced Elekta EVO, a CT LINAC, and you will see why I'm speaking of CT as opposed to combined CT LINAC, to complete the proposal about the possibility to adapt plans to the patient. Obviously, we want to to give our patient the best possible treatment. And in the hospital, we are always pressured by preparing new technologies and treating patient, increasing our standards, as we saw before for stereotactic radiosurgery, but also in adaptive. So we would like to achieve the right treatment technique for the right patient at the right time. As Professor Stathakis mentioned before, the patient is never the same throughout the fractions. Patient changes the anatomy, changes the condition. So how can we adapt to these changes? The solution of Elekta for the evolution of conventional C-arm LINAC is to provide a CT LINAC that is able effectively to provide a daily adaptation during the treatment. And what do we want to do with this new device? First of all, we want to treat all, meaning stereotactic radiosurgery as well as adaptation. Going further, can we do more than we used to do? What do we need? We say when we say we want to do more. Effectively, we would like to reduce margins, reduce toxicity. If we see where the target is, and we see this as we saw before with Unity, we can also see during the treatment what we are irradiating, not irradiating, making an fate, but really seeing this, then we can decrease margins, we can decrease the toxicity. And is there a community that is going to support this effort? So I'm gonna treat all this. Obviously, as I said before, from brain to thorax, head and neck, pelvis, abdomen. Nowadays, we have seen that we can deal with all indications. Not only about that, but also the capability of EVO is to treat non-coplanar beams. That's pretty much what we were also used to do with VersaHD. Integrating a full 6D positioning couch, which is a bit more than what we use to do with the Hexapod, because everything is integrated in the same couch, providing electrons with also non-coplanar beams, and an important adaptive toolkit and for the image guidance. So if we go a bit more into the details of this new device, of course we see a new and a fancier probably design. We allow, again, 6 times more modulation in a single arc than any other conventional LINAC can provide. And this was also explained by Dr. Russo when she was showing the way that the combination of Monaco and the Elekta LINAC could allow more modulation where is needed by accumulating more segments in those portions of arc where we need more modulation. Obviously, as I mentioned before, non-coplanar technique for both photons and electrons, twice as fast dose rate with high dose rate mode, integrated QA procedure, fast single isocenter for large field, multiple photons and electrons energy. That was also one of the characteristics of VersaHD. But most important of all is the introduction of Iris, new generation image quality. I will speak about that a bit more. So the treatment with VMAT got quite faster, and we have mutuated the idea of the adaptive workflow from the experience nowadays, 5 years of experience of Unity, where we realize what are the steps that are needed during the adaptive workflow. And if we substitute the imaging device from an MR with the CT LINAC, actually the problems we are trying to solve to adapt patients is the same. But how did we tackle this problem? Of course, one of the characteristics as Professor Russo mentioned before, the capability of Elekta to decrease the effective size of the leaves at any segments in and out of the target through the use of the transversal jaws. This is optimized in Monaco at each millimeter of the leaf thickness so that we can potentially reduce the leaf thickness to 1 millimeter. In combination with the accuracy of the leaf position and the optimization at each millimeter, we can achieve beamlets of 1 by 1 millimeters that we optimize. That's why in Elekta we are used to call, when we speak of radiosurgery, this as high definition radiosurgery. And we want to apply this even to SBRT and other non-intracranial lesions. EVO design, that's what Elekta calls the moonline setup, so the possibility to switch between two different setups for positioning the patient and the treatment modality. I don't know why they call it moonlight setup and not sunny setup, but whatever. So introducing iris. So this is quite important. So we make use of artificial intelligence to achieve image quality that could be as much as possible comparable to the native CT. So how did we do that? So we train a convolutional neural network based on calculation made with Monte Carlo to predict the scatter and the scatter correction to the images, so that from the calculation, taking minutes with Monte Carlo, we could drop to few tenths of seconds in the reconstruction of the images. Not only that, AI is also used for metal artifact reduction. That's what we use, and very handy in the case of dental implant or double prosthesis for femoral implants. And so what we wanted to achieve is the capability of having also combined that are naturally calibrated in Hansfield units, so that they are not just usable for IGRT procedures to position the patient, but as well as for optimization and re-optimization of the patient. So the algorithm that we used was Polyquant CT. Polyquant definitely it's a new concept because it integrates these reconstructions along with the capability to reduce the noise, increase the image uniformity, increase the MTF value, and provide the preview of the scatter and then the calibration in terms of combined or in terms of Hansfield unit. Here some example. At the left-hand side, you can see the today conventional combined CT that we realized with XVI. On the right-hand side, the native CT for this patient, and here in the middle, you can see the reconstruction made by iris. This algorithm has been tested also in different centers in Italy, in the Netherlands. So we had. Actually, Dr. Russo and I have been also the relator of a thesis about that. And so whenever we deal with a comparison between the native CT and iris CT, then we want to see the correspondence in terms of Hansfield unit, and this was the study. Therefore, we can effectively treat combined CT with the same Hansfield to relative electronic density that we normally use in the TPS. And that's another example for a second patient, again, to confirm the correspondence in terms of CT and combined CT. Last but not least, the capability of using what every day we use in terms of deep learning contouring method. Professor Stathakis mentioned Therapanacea, but we know even MIM, Protégé, Limbus AI, there are Envision, there are many on the market today. Each hospital has its own preference. We don't constrain anyone, but we wanted to have the same capacity of doing automatic contouring, deep learning based on CombiCT, as well as we are able with CT without having to adapt the model to a different imaging modality, because as a matter of fact, we are dealing with CT quality. So how do we apply this? Obviously, we apply this to IGRT. We still position the patient with this, and this is the equivalent in MR-guided radiotherapy language to the so-called adapt to position, but whereas in MR-guided radiotherapy, we just have the longitudinal movement in the MR scanner. Here we have 6 degrees of freedom, so therefore the relative ATP is the repositioning of the patient, but then still is valid in both offline adaptive and online adaptive, the adapt to shape procedure. Patient is different at each fraction. I can adapt to the new fractions, and I can adapt with the contours that are coming from, with the images that are coming from my, from EVO, the iris images that can be contoured through the formable registration or can be contoured through AI model. So AI auto-contouring is playing a role more and more. Adaptive treatment planning with Monaco made faster. We implemented and we deeply tested a fast way to re-optimize a plan starting directly from the segments by through a more advanced algorithm that having to redo the sequencing of the fluence with worm star optimization. Effectively, we can give it as an input to the optimization process the whole 3D dose grid of the reference plan, so that we can promote what we call today and is implemented in Unity ultra-fast ATS, and this will try to make it available also at EVO, the remote access possibility for the different stakeholders of the process, of the adaptive process, to connect from their own office, from their own computer. Obviously, we have technicians at the console of the machine, but also then we require for adaptation the consultation of clinicians. Sometimes for the same patient, there might be different clinicians. We see this especially in the abdomen area, where we have a clinician more expert in the lymph nodes, another one in the pancreas contouring, and they have to be able to concurrently work on the same patient from remote station. And last but not least, the medical physicist that needs to adapt the plan that might be not available at the console of the LINAC, but can remotely access. After the adaptation of the plan, definitely we need to QA the plan. Having the patient on the couch, we need a fast patient-specific QA. In this case, that consists into a recalculation of with an independent second dose calculation. Therefore, the plan assessment. And if needed, again, a verification scan and a scan at the end. So I will go quickly. Effectively, this summarizes a bit all the different possibilities, starting from CombiCT, going to contour review, quick plan calculation with the segments of the reference plan over the new CT at this point, to decide whether I should adapt or not. If I should adapt, then of course I can run plan adaptation, plan review, secondary dose check, verification CombiCT, and delivery. This is effectively it's not any different from what MR-guided radiotherapy has been doing today, and we are using the same tools that we have promoted in even for Unity, and in this case applied to Elekta EVO. This is powered by Elekta 1 Online. Elekta 1 Online is the suite of software application that come along with the Elekta software, comprising, of course, Monaco, also MIM today for faster and more advanced contouring functionalities, but also Prono and DOS check that we use. So these are definitely the most important steps from auto contouring, planning, plan adaptation, and QA. But what about speed? Obviously, we need speed for this procedure, because whenever we implement online adaptive, then the patient is waiting for us on the couch. So we want this by minimizing the number of clicks that we want. That's why we make strong use of scripting mechanism of MIM and Monaco combined, parallel workflow, and concomitant use of the concomitant users getting access to the workflow, deep learning algorithm for contouring, for imaging reconstruction. We spoke about that, and so the possibility of having faster calculation. How much fast? As we did in the past for Unity, we implemented GPU MCD Monte Carlo, implemented over GPU, and we are bringing this even to the conventional Linux, to Elekta EVO. So now we extended GPU MCD to MR-guided radiotherapy, to CT-guided radiotherapy, even to protons calculation. So we have a 5 times faster calculation with GPU as opposed to what we used to have for CPU, meaning a pros that could optimize between 30 seconds to 1 minute, and then the neck, few minutes, 2-3 minutes, we can have an head and neck plan. So not only we apply GPU techniques to Monte Carlo, but even to the optimization process. In the past, with MR-guided radiotherapy, we had still the optimization on CPU and Monte Carlo calculation on GPU. Since version 6.2, 6.3, everything will be combined, and even the optimization will be twice as fast through the use of GPU. Plan QA, as I said, once we create the adapted plan, we need a fast response on how good is our calculation over the patient, and that's what we do by Elekta proposed TeamQA, developed in collaboration with Dosisoft. There are even other solutions. One of the particularity of the Elekta 1 proposal is also to be open to third-party integration. The remote access obviously increases productivity, ease of use, and it's a fast and secure procedure. So, just to recap briefly, for online and offline, the adaptation toolkit allows better visualization throughout all the body, and effectively the same user experience, whether we are dealing with CT-based, CT-guided radiotherapy or MR-guided radiotherapy. People are not, 5 minutes? One. Okay. People are not alone in this. The same way we promoted the MR-Lina consortium. I'll get there, skipping a few slides about QA. but obviously people are constantly assisted with IntelliMax. In IntelliMax, we also implemented AI solution to preview possible faults of the machine. So all the machines that are connected with IntelliMax are constantly analyzed by this software that is giving us preventing messages of what possible fault we could have in one of the components. Elekta Care to increase even the knowledge of the system and up to 90% uptime guaranteed. And last but not least, as we promoted the MRgRT consortium, now we are extending this to Elekta CityLinea Adaptive Consortium. In the consortium, we have different tumor site groups, people that implemented the adaptive technique for different sites, head and neck, pancreas, rectum, brain, etc. So it's a possibility, it's a scientific community. We exchange ideas, experiences, we publish in with multicentric, in a multicentric way. Thanks for your attention.
Thank you very much. Thank you very much for this excellent presentation.
Thank you.
So we will have any questions from the audience. I have one question for you.
Okay.
Okay. Which method do you use to calculate the total dose from day one to the last day of the treatment? I mean, do you take into account, for example, the deformable maps from day to day?
No, we don't.
And apply them to the dose distribution?
No, we don't. We don't for the simple reason that you mean forward dose accumulation. We have the capability of doing this. The only problem the only reason why we didn't implement it clinically yet is because of the uncertainty is in the voxel tracking. The uncertainty in the voxel tracking whenever we perform the formable registration, and then we are not sure about the possible error in the deformation vector field that we use to warp the dose onto. Obviously, whenever we use the formable registration to propagate contours, whenever we see that the contour is not accurate, we can easily, or the radiation oncologist can easily correct. In the case of those, that's not possible. We should be providing a matrix to assess in which region, pretty much like we do with the gamma index, we can rely or not onto this dose warping and the confidence. So that's too risky of higher toxicity in certain sites, for instance, the abdomen, to rely on this to optimize on the top. So the strategy is another one. The strategy is to get the best possible dose of the day given the anatomy of the day, and then at the end of the fraction doing a backward dose accumulation to compare with the previous reference plan.
Thank you.
You're welcome.
Is there any other question?
So if we would use the MR-guided radiation therapy, didn't we miss out information about the bone density?
You do. Elekta's way to account for that is that we transfer the density as a bulk density override to the contour structure. So for every reference plan, we contour all the bones, we match them, and then during adaptation, during the adaptive plan, the bulk density of that bone, the mean of that is transferred to the contour that has been adapted. So all the MRI plans is not only the bones, is everything. We don't have any density, any electron density information from the MR. So for every structure, we are applying the bulk density of the reference plan. So the bladder, the mean energy of the bladder is what, 0.97. This 0.97 will be as a bulk density override to the new bladder on the MRI. The density of the rectum, of the bones, of everything, of the all the other tissue that is not contoured is going to be averaged and is going to be applied as a bulk density override to that same structure.
So we changed a little bit the weighted beams, the weight of the beams that we usually do in a CT-guided radiation therapy, as I understand it, if I understood right.
Can you repeat the question a little louder?
Yeah. So as far as I know, if we make a CT-guided radiation therapy, we usually change the weight that the beams hit the patient. So if I understand right, according to what you said, we kind of use radio frequencies now to treat. Okay.
No, for planning purposes, the densities are overridden using the CT information.
Oh.
Like when I was that little and Dr. Kappas was teaching me how to do inhomogeneity corrections, remember with Baton and all that, you're applying all these density corrections as in infinite slabs. It's similar, so it's all bulk density now.
Okay, thank you.
Any other questions?
Oh. Dang it. Yes, Dr. Maris.
Well, I'd like to ask you this question. You're familiar with what we call pseudo-CT coming from the MR?
Yes.
Have you any experience on that? Did you use this method?
Yes.
Okay.
So there are several solutions. To date, the only FDA approved in the USA is the Therapanesia that we have acquired. We are in the process of releasing it for use. We have done an extensive testing, and we will be using it for prostate only. It's only for prostate and brains right now. I have some slides on the other talk that I have. I didn't go over that, but we are thinking about using it at least for the reference CT. We're trying to find ways to use it for daily CT, for daily MRI. The workflow within the unit needs to change for us drastically to introduce this layer, but it's not impossible. There are some places like the Medical College of Wisconsin that are using MIM to do all the contouring instead of the Monaco contouring. We're looking at that option as well as the synthetic MRI using for prostates only, using the Therapanesia solution.
What do you think about this future? You think that pseudo-CT will evolve on that in relation?
I think the MRI will be playing a larger role in radiation therapy overall. I don't know if it's going to be through the means of pseudo-CTs, but MRI for radiation therapy usage is going to increase drastically.
Yeah, we know that about the gels and all this stuff, so it's okay.
But it's harder for the companies and research to do synthetic CTs for abdomen, synthetic CTs for other parts. I think prostate was either because there's a lot more data or more curated data, we're able to to be there faster.
Thank you.
Thank you.
That's all
Unfortunately, we have to close the symposium because we have run out of time.
On behalf of the organizing and scientific committee, we would like to thank Elekta for the help and the support.